One of the largest trial which showed first time mortality benefit. There are previous other trials which didn't show benefit. That's the reason this has become one of the landmark trials. I'll talk about the background of the trial. And as we know, kidney failure is quite a severe disease and it can affect morbidity and mortality of a person. And the well accepted therapies include hemodiafiltration, hemodialysis and home hemodialysis, which is becoming more and more popular. In fact, we have many patients on home hemodialysis in Bangalore. People are choosing that because of convenience and comfort. Clinical practices differ from area to area. If you look in few countries like Australia, where home hemodialysis is very, very popular, and few countries where there is no home hemodialysis at all, especially in US. I'm not sure how it works there, but definitely in-center dialysis is much more in few countries, including India. So hemodiafiltration is a form of renal replacement therapy which utilizes both convection and diffusion. Diffusion, as we know, is the standard of therapy for in standard dialysis. Compared to standard dialysis, hemodiafiltration removes middle molecular weight and larger molecules. Some studies have suggested that hemodiafiltration definitely improves the clinical outcome. Only problem is hemodiafiltration needs complex machines, and you need to have a very good water system, and it increases the demand of both the people running it, and running costs are higher. That's the reason it has become very common in Europe and Japan and few countries to do HDF. US has not yet approved yet. They are only doing regular hemodialysis with high flux dialysis, and most of the clinicians, most of the centers, they use hemodiafiltration for online hemodiafiltration. I'll come to that, what is the difference. And as I mentioned, it's not there in US much. Here basically you need to substitute the fluid along with the regular dialysis. So you add both convection and diffusion, and it has shown definitely mortality benefit. As we all know, mortality is much higher in our dialysis patients. So people have made attempts to look at how to improve the dialysis. So if you look at urea clearance, we have almost achieved what we can achieve maximum. I don't think we can go more than this, what we are doing with respect to urea clearance. So in hemo study and other studies where they tried to look at clearing more of urea clearance, they didn't find any mortality benefit or morbidity benefit. That's the reason. So we have already hit a high in urea clearance. So we need to see how we can improve otherwise if we can add other modalities. So we all know that most common cause of mortality in dialysis is cardiac mortality. Uremic toxins definitely contribute significantly, and they are divided into low, middle and large molecule. I did not tell to all the elite audience here. We all know that uremic toxins are the main ones which contribute to the cardiovascular risk, one of them being AGE products and beta-2 microglobulin, which Dr. Giri spoke about in his previous talk. And the next important one is FGF23, which is known to contribute to cardiac morbidity. So large molecular large molecular weight molecules contribute to significant cardiovascular morbidity. Extracorporeal volumes aim at removing these larger and middle molecules. So definitely convective therapies have better clearance compared to diffusive treatments theoretically. So are we seeing this in clinical practice? Let us see. By definition, hemodiafiltration is an extracorporeal therapy which combines diffusion with convection, and it uses convective volume almost to the tune of 20% of the blood volume, and fluid balance is maintained by sterile infusion fluid. So how is it done? Basically, this is high flux dialysis, which we all know, where there is little bit of backfiltration, not much of backfiltration is seen here. This is classic hemodiafiltration, where it is not online. You need to substitute fluid with the help of bags. This used to be the practice earlier. Now we have online hemodiafiltration, where you continuously infuse substitution fluid along with dialysis. So what happens? Basically, you have diffusion here and you are adding convection. How much of this convection we add in hemodiafiltration? The standard recommendation is to use minimum of 23.5 or 24 liters to keep it round figure, where they have seen morbidity and mortality benefit and survival benefit. That's the reason that is the minimum amount of fluid which is used in hemodiafiltration in a period of 4 hours. That is 240 minutes. So what are the advantages of doing this? It theoretically increases the clearance of middle molecular weight. The fluid is more biocompatible, and it also improves the hemodynamic stability of a patient. As we can see here, the beta 2 microglobulin and bigger molecules are cleared better by hemodiafiltration. Green represents hemodiafiltration. As the molecule becomes bigger, hemodiafiltration takes over compared to hemodialysis, which is more effective in smaller molecules. So this is the circuit which is used in hemodiafiltration. The fluid can be given either pre or post. Most often it is given post to improve the clearance value. So if you look at the molecular clearance, the blue one indicates hemodiafiltration, where you can see as the molecule becomes bigger, the clearance is better. Both beta 2 microglobulin and FGF23 is cleared better in hemodiafiltration, which was shown to be statistically significant. It also helps in reducing the inflammation because it clears the inflammatory mediators. It also suppresses reactive oxygen species production and improves antioxidant capacity. It theoretically is supposed to reduce the generation of advanced glycation end products by the ultra pure dialysate which is used in dialysis. So this is the ultra pure water which Dr. Girish was talking about. You need to have this separate. This is apart from RO system what you already have. This is quite an expensive filter. As you can see here, this is the regular filter what you use in dialysis, but this is of huge size. So the water runs through this ultra pure water, which is infused into the patient for convection. So the quality of this water should be of the same of an infusate fluid. So the infusate fluid HDF must be sterile and non-paragenic, because this is going directly into the patient's intravenous system. So it is supposed to reduce inflammation, improve the appetite, give better response to erythropoietin, reduce the risk of atherosclerosis and reduce MIA complex. Definitely it improves the appetite. Hemodynamic stability I have already spoken about. This is the mechanism it works. The key difference being the larger molecules are cleared better in hemodiafiltration. This is the same cartoon to show that how we do hemodiafiltration. Coming to the trial as such, previously there are 4 trials which came on hemodiafiltration. Turkish trial, French trial, contrast trial were actually inconclusive. They didn't show any benefit. The only trial which showed little benefit was ESOL's trial, which showed that anything more than 23 liters gave a survival benefit. So to take away the limitations of the previous studies, the CONVINCE trial was planned. This is again to show that only trial which showed help was in ESOL trial. So trial design was basically they divided into 2 arms. One is hemodiafiltration, the other one is high flux dialysis. It was a randomized multi-center trial. Basically in Europe it was done, and all the patients were on 3 times a week dialysis. They should have completed minimum of 3 months of dialysis period so that they can be included in the trial. So the primary objective was all cause mortality. All the other things were only secondary objectives. It was done in 61 centers in 8 European centers, and they were initially they conceived around 1,800 patients to include, but in between because of the COVID hit, the recruitments were lesser. So they looked at basically 1,360 patients, and each of them they were divided into 2 groups. One group being high flux dialysis, the other one being HDF, and it was a 3-year follow-up period, which was a good time to see whether there is any survival benefit. The inclusion criteria were standard. They should be on regular dialysis, more than 18 years, more than 3 months of dialysis, and they should be on 3 times a week, 4 hours dialysis, 240 minutes dialysis, and all of them were on standard convection volume of 23 liters. Who are going for transplant, lesser life expectancy, they were removed, excluded. This was the countries which were involved, basically most of the European countries in 7 clinics. This is the volume which was achieved. Basic characteristics of the patients were same, be it age group, be it body mass index, and the fistula were actually the maximum used. Blood flow rates were similar, and all of them had similar cardiovascular and other comorbidities. As I mentioned earlier, it was standard 3 times a week dialysis, average if you can see here 244 and 245 minutes, and all the parameters were almost similar when they started the trial. And the volume of fluid achieved was almost, they achieved 92% of the population, they were able to achieve 25 liters per session. As we know, because we are adding convection, KT by V increases in HDF, so that's the reason KT by V difference was there. And Primary outcome in this group was improved survival, that is lower rate of mortality almost to the tune of 23% compared to high flux dialysis. This was over a period of 3 years. They were able to demonstrate survival benefit. Secondary outcomes, cardiovascular outcomes were actually better. The only negative limitation of this study was that they recruited most of the patients who had the survival benefit were younger population, people without diabetes, and none of them had any cardiovascular morbidity prior to begin with. So that was the only limitation of this study, but otherwise they were able to achieve 23 liters. All of them had good access, and sample size they couldn't achieve fully as conceived earlier because of the COVID pandemic. The conclusion of the study was lower risk of death from any cause in population who were on high volume hemodiafiltration compared to high flux dialysis. This was a randomized control design of multicentric in magnitude, so it had good power to it, and definitely the trial design was good and it showed better benefits. So what are the benefits of hemodiafiltration for the postgraduates? These are all the benefits theoretically, plus practically also we do see most of our patients who are on hemodiafiltration need lesser erythropoietin, and in fact they don't need any calcium phosphorus supplement, phosphorus binders at all. In fact, many of our patients are on extra phosphorus because their phosphorus is so low. We are adding convection, so phosphorus is removed, and definitely beta-2 microglobulin and other molecular clearance is better in this population. We have an ongoing trial where one of our technician is doing a PhD on comparing of regular dialysis, hemodiafiltration, and high flux dialysis. Hope we get some positive results with that. To conclude my talk, there is growing evidence to show the benefit of online hemodiafiltration. Hemodiafiltration offers advantage over HD, especially with respect to improved clearance. It has better biocompatibility and it gives better hemodynamic stability, and this was again shown in CONVINCE trial, especially with respect to mortality benefit. Thank you very much for your patient hearing. Any questions? I can.